Welcome to EJB Talks, Rutgers Blaustein School experts in policy, planning, and health, where we talk with our faculty and staff experts, as well as students, about how the fields of public policy, urban planning, public health, health administration, and public and urban informatics affect your lives. Welcome to EJB Talks. I'm Stuart Shapiro, the Dean of the Blaustein School, and the purpose of this podcast is to highlight the work my colleagues and our alumni in the fields of policy, planning, and health are doing to make the world a better place. We're going to speak today with a relatively new faculty member in our health administration program, Professor Irina Grafova. Irina works on such varied topics as provider burnout and medical debt. Welcome to the podcast, Irina.
Thank you for having me, Stuart.
So, longtime listeners know I always start with pretty much the same question, at least with first-time guests. Let's hear your origin story. How did you become interested in researching issues around healthcare?
Well, when I was in graduate school, I actually thought I would become a labor economist. I was interested in the impact of health behaviors on labor market outcomes. And as I was doing more work in this area, my interest in health economics began to grow. Um, what I did not realize at the time was that I was mirroring the origin story of health economics itself, which evolved from labor economics.
And so that got you to, and you decided just to go whole hog into health at that point.
It was a gradual process. It was a
Uh-huh.
gradual process, yes, but this is what got me involved. I worked with some great people who worked on the cl- um, in the area of both labor and health economics, and so they got me interested.
And you seem to still be very interested in how healthcare interacts with other aspects of people's lives. Is that
Yes.
right? Yeah. Well, one of those aspects of people's lives is medical debt and debt in general. Can you tell us how you became interested in that subject?
Well, this probably originates actually even to my early research on, like I mentioned, on health behaviors. Because one of the things I've been finding in the earlier research is that health behaviors are related not only to labor market outcomes such as wages, but they also related to some of the family financial indicators, including indebtedness. So I became then interested in general how health is related to family finances,
Mm-hmm.
how they're linked, and thinking about those linkages and realizing that this is a two-way street.
Mm-hmm.
That on the one hand, you can have um, adverse economic shocks affecting health, for instance, because adverse economic shocks may mean that family would need, say, to cut on the healthcare spending, which would adversely impact their health status. But it's also possible that adverse health shocks would be affecting the family finances because they, for example, need to finance their care. And so sometimes that happens in the form of debt financing.
Gotcha, gotcha. And so um, there's this interaction between medical debt and credit card debt that you've talked about. Um, Tell me a little bit about that and how it can really be crippling for people.
Mm. Well, I think I probably need maybe to start by talking about why disease can lead to different kinds of debt
Mm-hmm.
and why people go into debt when they get sick. And there are a few reasons for that. One of it is that disease often comes with sizable medical out-of-pocket costs, even for those who have health insurance. So those out-of-pocket costs have to be paid, and people don't necessarily have the income or the assets to pay for those costs. But at the same time, when you get sick with some of those diseases, it comes with productivity loss, for instance, because of the functional limitations onset. And that productivity loss may result in the lower earnings for you, or actually, it could be that somebody in your family has to take care of you, and then they also cannot work as much. So, on the one hand, when you get sick, on the one hand, you have higher medical out of pocket spending, but on the other hand, you have lower income inflow. And so this puts families experiencing adverse health shocks between the rock and a hard place. And so then they try to finance those spending so they can go into medical debt. Maybe they don't pay their medical bills, or they have to pay it in an installment, or not at all, or they put it on a credit card, on a regular one, or a medical credit card. But sometimes they also have to adjust their lifestyle. Maybe it's a new diet. Maybe they have to make some kind of alterations, adjustments to the home. So that means that they may need to go to the other forms of debts, whether it's a credit card or some of the other forms.
Yeah, preventative measures like you mentioned, a better diet, they tend to be more expensive.
Yes, yes, yes. They have to, if it's a healthier diet that now they have to adhere to, it would be more expensive. If they now they will turn to, say, eating more fresh fruits and vegetables, they tend to be more expensive than the processed food.
Right, right. And like you mentioned, the other accommodations you might have to make to your home or anything else also means more money that you spend at the same time that less money might be coming
Yeah.
in. It's a basic inflow outflow problem, basic budget problem for people who are
Yes.
very income constrained, perhaps to start out with.
And I think one of the issues here is that why people go into that is because of so much of the family's budget is spoken for. There is this big consumption commitment. You're committed to spending part of your income inflow on the mortgage. You have to pay, I know, your car insurance, the gas, and other things. And so there is actually relatively little for a lot of families left with that they can somehow adjust in these kind of situations. And so a lot of them have to resort to debt.
Yeah. So I'm a public policy person at heart, and I don't know that government or policy is the answer here. Maybe it's answers within the healthcare system. But what can we do about this? Are there solutions out there to alleviate this problem of medical debt that at the same time leads to greater expenses or perhaps lower income in other areas?
Well, uh, it's a it's not an easy question to answer because there are obviously some band-aid solutions.
Hmm.
Okay, and then there are some solutions that potentially can address root cause of the problem. The solutions that would address root cause of the problem, they are much more challenging because they require, for instance, to address the issue of the high medical costs. And this is a fundamental thing, very, very hard to address. But there are certainly, even within the current system and within the current cost system, there are some of the band-aid, if you like, solutions that we can um, try. And one of those solutions could be wider proliferation of the financial navigation programs. These are the programs that very often we can commonly find in, for instance, oncology care settings, and they can help patients with a number of things, including a choice of health insurance. There are a lot of people who don't have the health insurance who best fits actually their needs, and they can pick a different one at their job or within the Medicare system that actually will pay better for what they need.
So I like band-aids because the wholesale solutions will take time. I mean, band-aids are always a step on the way to the wholesale solution. I would assume strengthening the social safety net would also presumably help. It's an income, guaranteed income, or something along those lines. There
Yeah.
would at least be some help in this area as well.
Yes, this is another area because we have SSI, we have SSDI, but our income support policies, especially targeting people with disabilities, they have been created long time ago, and they have been created, I'd say, with a slightly different view of disability. They've been created more with the view of these people are disabled and they're going to die soon. What
Mm.
has been happening, for instance, with cancer care, is that we learn to treat cancer much better. People live with cancer much better than they used to. Mortality day rates are down. There is a greater survivorship, but that comes at a cost. The cost would be long-term functional limitations, and our income support policies targeting people with disabilities, they have not been designed with this in mind. So actually revising some of those income support policies, I think would be really helpful to a lot of people who have who experience financial burden of the disease and functional limitations because of those disease.
Yeah, as our ability to prolong people's lives under medical conditions improved, we've actually exacerbated this debt problem, if you will, because and it's a good thing that we people live longer, right? We want that to happen. We want them to be able to enjoy life and children and grandchildren, etc. But we can't just do that and ignore the financial implications there. Before we move away from your research, I do want to let you touch on the new work you're doing on provider burnout. Tell me about what you're looking at there.
Okay, so this is the area of work that kind of grew out of my interest onto multidimensionality of the socioeconomic status and health, because I used to do some of the work on the effect of the environmental health, mostly focusing on built and social environment. And this body of work grew out during the COVID-19, when basically work environment changed so much, especially for the healthcare provider. So I collaborated with a great colleague of mine, Dr. De Cordova from the School of Nursing, and we did the project during the COVID pandemic that focused on acute care nurses' stress and burnout during um, what ended up being the end of the first wave and the beginning of the second wave of the COVID-19. And so this is what kind of got me interested in this area of the research. And what I realized is that providers, particularly nurses, experience a lot of pressure, a lot of both physical and emotional burnout, and that this is a big problem in the healthcare system because of the turnover, because of the quality of care implications, and so on. And the healthcare system is trying to address this, but I think there is a lack of evidence-based approaches on how best to address the nurse burnout. And this is what I am interested in, to to see what kind of approaches are working. They should they be employment based, not employment based? How best potentially to roll out some of those interventions that um, they are accessible and that there is an equity in access to them. So I'm interested broadly in the provider burnout issues and how well the system is prepared for those issues and what healthcare system can do to help alleviate it.
I'm excited to see where this research goes, and it's a great fit with your moving into our health administration program. Can you talk a little bit about how your research informs your teaching as you've come over to become a health administration professor?
Yeah, so let me give an example of the nurse burnout research. A lot of the MHA graduates want to go and work in the hospitals, and nursing is one of the biggest expenses actually for the hospitals. Nursing industry, they experience the shortages and the burnouts and the turnover prior to COVID pandemic, but pandemic definitely exacerbated those issues. So talking to the talking to the students and the health administration um, about those issues, I think is very important, because I can highlight to them the importance of the workforce management. I can help them to understand the factors that are contributing to the nurse turnovers, so that students appreciate the complexity of the staff retention strategies, that help to prepare them to implement some of those solutions when they become the future health administration leaders. I think it is important that they learn about the importance of evidence-based practices to reduce the burnout and the turnover.
That's great. Well, let me wrap up with a teaching question and about your transition here. What surprised you about teaching health administration?
Uh, I think it has been uh, the interdisciplinary nature of the student body. I come from public health, and I know that in public health, the student body is very interdisciplinary, comes from different backgrounds, like to the graduate school. But I didn't realize that there will be a diversity actually of experiences in this health administration student body and in their backgrounds. They really come with very diverse set of interests and the backgrounds, and it's exciting to teach them and actually to learn from them, because a lot of them have real work experience, and uh, having the classroom where they, I think, enrich each other with their experiences and enrich me, and then I share something with them. I think it's a great privilege.
That's great. Well, we are happy to have you, that's for sure. Thank you so much for coming on the podcast.
Thank you for having me.
Also, a big thank you, of course, to Tamara Swedberg and to Karen Olson, who helped make this podcast happen. We'll see you next week with another talk from another expert from the Blaustein School. Until then, stay safe.
Bye.